Incontinence is common among older people. The impact of incontinence is significant. Incontinence is not an inevitable consequence of aging. It can be treated after a proper assessment. A lot can be done to prompt the comfort and dignity of older people with intractable incontinence. Incontinence is defined as any involuntary leakage of urine, although more common incontinence is not inevitable in old age, and much can be done to prevent and treat it. A positive attitude and a thorough assessment can mean maintaining dignity and independence for most people. The prevalence and impact of incontinence: up to 1 in 5 women and around 1 in 10 men over the age of 65 suffer from incontinence. The prevalence increases with increased age and comorbidity. Two-thirds of care home residents are incontinent of urine. Changes in urinary tract with aging: shortening of the urethra, post-menopausal atrophy of the urethrium, reduced bladder sensation, reduced destrusor muscle function, increased residual bladder volume, less effective urethral closure, postmenopausal bladder sensation reduced, muscle reduced, the muscle responsible for the urine retention, increased residual bladder volume, less effective urethral closure. The drugs that can worsen or precipitate incontinence: diuretic, sedatives, alpha blocker, any drug with cholinergic properties. Here, types of urinary incontinence in older age: urge, stress, mixed, voiding problem, functional incontinence. The definition and cause and symptoms: urge, the complaint of involuntary leakage of urine accompanied or immediately preceded by urgency, overactive bladder, frequency, urgency, nocturia, unable to delay voiding, stress, involuntary leakage of urine on effort or exertion, coughing or sneezing, weak pelvic floor muscle, incompetent urethra, leak urine on exertion, coughing, laughing, sneezing. Mixed, the complaint of involuntary leakage associated with urgency and also with effort or exertion, OAB, and weak pelvic floor, overactive bladder, combination of the above. Voiding problem, the generic term of obstruction during voiding, characterized by increased destructor pressure and reduced urinary flow rate. Prostatic hypertrophy, destructor failure, neurogenic bladder, fecal impaction. Symptoms: poor stream, post-nocturnal dribble, may have large residual urine volume. Functional incontinence, inability to toilet independently. Extrinsic factors such as immobility, confusion, inability to access toilet facility. Incontinent if carer unavailable or unable to communicate needs. There are 5 main types of urinary incontinence in older people: urge incontinence or overactive unstable bladder, stress incontinence, mixed incontinence, voiding problem due to obstruction or neurogenic bladder, functional incontinence due to an inability to get to the toilet, confusion. Key component of a continence assessment: history of onset, duration, symptoms, previous medical or surgical obstetric history, medication, assessment of vocational abilities, examination of the abdomen, the rectum, urine analysis, urea and electrolyte, glucose, prostate-specific antigen in men. In addition, patients are asked to keep a bladder diary. It's also very important to ask about bowel problem, as constipation lead to fecal loading, can cause urinary problem. incontinence clinic. Further assessment are typically undertaken while include post-micturition bladder scan to look for evidence of voiding problem, measurement of urine flow using special comedy, a quality of life score, measurement of body mass index, treatment, general measure that can help promote continence in older people, staying active, losing weight if necessary, drink water there rather than caffeine and alcohol. Yes, to the following suggest stress incontinence. I leak when I cough, laugh, sneeze, exercise. I leak small amount of urine. I know when I have leaked, only my pants get wet. I leak during sex. Yes, of the following suggest urge incontinence. I have an urgent need to pass urine. I sometimes don't reach the toilet in time. I get up more than twice at night. As I pass urine more than 7 times a day. I get very wet. Yes, for the following suggest voiding problem. My urine flow stop and start. Sometimes I can't pass urine straight away. I sometimes feel I have not emptied my bladder properly. I have a feeling of fullness in my bladder area. I get frequent urine infections. Yes, to the following suggest functional incontinence. I have a lot of healthy problem. I have problem with memory and concentration. I need help to move about. I have problem adjusting my clothing. I have a feeling of sadness, depression, and loneliness. Bladder control issue. It's a big problem. 25 million American adults have incontinence. One half of women over 60 have incontinence. 60 have incontinence. Billions of dollars are spent each year on supplies. Women wait an average of 6 years before diagnosis. 80% with incontinence curb some activities. 50% with incontinence think they have to live with it. Type of urinary incontinence: stress urinary incontinence, overactive bladder, destructure instability, intrinsic sphincter deficiency, overflow incontinence, here the urethra, bladder, vagina, normal bladder function, the uterus, bladder, stay uh, in front of the uterus, the urethra, here the internal urethral sphincter, external urethral sphincter. When you exert stress urinary incontinence, when you exert, you squirt. Loss of urine with sneezing, coughing, laughing, lifting, exercise caused by anatomy change, weak urethra, bladder muscle normal. Intrinsic sphincter deficiency, sphincter tone is weak, so you leak, gush of urine when stand or move, caused by weak sphincter from injury, previous surgery, and this is common. Overflow incontinence, my bladder runs over, leaks intermittently, poor sensation, poor time, usually large bladder, neurologic problem or obstruction. Types of urinary incontinence, as we say, stress urinary incontinence, overactive, intrinsic sphincter deficiency, overflow incontinence. Test bladder diary. We write the amount of urine and time and frequency for 5 days, for 7 days, and compare them with other 7 days. Test urodynamic, feel bladder and check pressure, check for normal sensation with feeling, check for leak with provocation, check total capacity, check for effective time, check urine analysis, pelvic floor evaluation, test, treatment, sling used for stress urinary incontinence, outpatient surgery, takes about 30 minutes, permanent mesh placed below the urethra, provides support, 95% cure, a significant improvement. Here, Maureen has urinary incontinence. Maureen had 52 years, married, has 3 children, education. She is teacher, but suffer from incontinence, unable to control bladder, urgency frequently, can't get to the bathroom in time, urinate 15-20 times a day, wears pads every day, has stopped going out, test done, physical exam, urodynamic, bladder, diary, pelvic floor evaluation, option conservative versus surgical treatment, topical estrogen, dietary change, Kegel biofeedback, medication, finally neuromodulation, solve the problem, diagnosis to surgery for 5 years, hospital stay few hours, full recovery few days. Neuromodulation, solve the problem, treatment, conservative, topical estrogen, dietary changes, casual exercise, bowel care, bladder training, treatment with casual, contract the muscle that stop urine stream, or 60 to 100 squeezes a day, do when waiting, squeeze, hold for few seconds, release, squeeze, hold for few seconds, release, squeeze as many times rapidly, can use vaginal weight, the casual. This is the commitment of the muscle responsible for urine retention. It's effective